TopMedTalk.
Good morning. My name is Charles Hogue. I'm the professor and chair of Anesthesiology at Northwestern University in Chicago. I wish I were welcoming you to Chicago in person, but I guess we'll have to wait for next year with all the disruptions of the pandemic. My topic is redefining hypotension based on real-time cerebral autoregulation monitoring. Before I get started, I might just add that this work has been supported by the American Heart Association, the Anesthesia Patient Safety Foundation, the NIH, and Covidien Medtronic, and now Edwards Life Sciences. And I've been a consultant for several companies, which I list in my slides, some of them which are related to this topic, some of them which are not. So the use of blood pressure monitoring in the operating room really can date back to the turn of the 20th century. Harvey Cushing was the first to advocate for this. Harvey, of course, was the father of neurosurgery and the father of endocrinology. And he had recommended that we take blood pressures in the operating room and record them, hence the start of the anesthesia record, I suppose. And this was first reported in 1903 in the Boston Medical and Surgical Journal, which is the precursor to the New England Journal of Medicine. And it wasn't really taken up with a lot of enthusiasm for about another 20 years. And then by the 1920s, people were routinely monitoring blood pressure during surgery. But it took about another 10 decades, and we're still trying to figure out what constitutes hypotension. There's been a lot of opinion, a lot of information based on animal studies, but it really went for another 100 years before we had a clear consensus of what constituted hypotension. There's still no agreement. There's still a lot of debate. One of the breakthroughs, I think, in this regard has been the electronic health record. It's allowed the acquisition of a large amounts of digital data and along that can be tied to patient outcomes. And one approach to defining hypotension is to link certain blood pressure cutoffs with adverse events retrospectively. And what has been noted is that about a third of the patients will experience blood pressure below 65 minutes for 10 minutes or longer. So a great number of our patients, this is non-cardiac surgery, but a great number of patients will indeed suffer hypotension during surgery. And what multiple investigations have found is that a MAP, mean arterial pressure less than 65, is associated with an increased risk of acute kidney injury, myocardial infarction, and even mortality. So investigators have moved this definition of a MAP less than 65 millimeters mercury to constitute hypotension. And in fact, they've also now, there's a movement, certainly in the United States and elsewhere, to equate a MAP of 65 millimeters of mercury for less than some time period, usually 10 to 15 minutes, as actually an indicator of quality. In other words, the frequency that your patients have hypotension or blood pressure less than 65 for more than 15 minutes is now can be reported as a quality measure. In the United States, that would be to our Centers for Medicaid and Medicare services and what we call merit-based incentive payments. So it has a lot of implications for quality now. But one of the problems is that if you go through these data carefully, this is limited to non-cardiac surgery, and it's also often excluded emergency surgery, excluded neurosurgery, obstetrics, and certainly cardiac surgery. And if you look carefully at these studies, the frequency of perioperative complications and how carefully they look for them varied a lot between studies. So if you do routine creatinines or troponin measurements on patients, you're more likely to find the complications versus those that come forward through the process of clinical care, where these things are only measured when there's a problem. So the rates of complication varied tremendously between studies. Another concern is that these studies, there's underrepresentation by women and minorities. So whether this data can be extrapolated to all patients is not clear. And really, a definition of hypotension is very difficult because in the end, everybody has different situations. So if somebody has a tight left main coronary artery stenosis or renal artery stenosis, is a MAP of 65 really the right pressure? Is this really accurate? I would dare say no. And again, all these associations have been associations. It's retrospective analysis that looked at associations between blood pressure cutoffs and outcomes. It's not necessary causality. In other words, cause and effect has not really been proven in all these studies. In fact, there's a recent study that was just published in Anesthesiology in September that shows that post-operative hypotension is more stronger of a predictor than intraoperative hypotension. In fact, when you include, for predicting myocardial infarction, so when you include post-operative hypotension, intraoperative hypotension is not a predictor of troponin release. So it shows you that these associations are not necessarily causality and they're not airtight. There's a lot of work that I think we need to do. There's really a paucity of data that would show maintaining mean arterial pressure greater than 65 actually reduces acute kidney injury, a myocardial infarction, or death. There was one study, the HYPE study, published in JAMA, where they randomized people at several centers in France to having a blood pressure of a certain percentage of baseline awake blood pressure versus a control group where systolic blood pressure wasn't treated until it was 80 millimeters of mercury, which I think a lot of us would think is pretty low. And that study did show that the personalized individual pressure based on baseline blood pressure actually had better outcomes than the patients who were allowed to have systolic blood pressure of 80. So there are information from that study that would suggest that hypotension is indeed a modifiable risk factor for outcomes that perhaps we could do something about. So one of the tenets of hypotension that we sort of develop is that as long as the blood pressure is above the lower limit of cerebral autoregulation, then it should be okay for perfusing the brain and likely other organs. Now, I think take a second to step back, as we know that blood flow to many organs, particularly the brain, is autoregulated, meaning that blood flow is kept constant over a range of blood pressures, and that the blood pressure may vary, but flow stays the same, and this would be the plateau of the autoregulation curve. But when blood pressure goes below the lower limit, now flow is pressure dependent, so the lower the blood pressure, the lower the flow. So we've always sort of been taught that as long as the blood pressure is above the lower limit of cerebral autoregulation, flow to the brain is ensured and likely to other organs. Now, that may necessarily be true, but the other organ bit, but this has been a basic tenet that we care for patients with. And the cutoff that we've been taught for the lower limit of autoregulation is 50 millimeters of mercury, and the upper limit is 150 millimeters of mercury. And that dates back to this publication by Neil Lassen in the Physiological Reviews back in 1959. And it's interesting to look at where this is derived is that Neil Lassen went back and looked at 11 studies where they quantitated cerebral blood flow against mean arterial pressure. And then he plotted these studies of the cerebral blood flow versus blood pressure. And then he hand drew a curve. And he decided to make that inflection point at 50. I might point out that patients, I think 3 and 4 had preeclampsia, so they're really, keep that in mind, that whether they have a normal cardiovascular system is debatable. But regardless, Lassen drew this curve by hand. He did not use any kind of mathematical modeling. He drew it by hand, and he decided to put the blood pressure at 50 as a lower limit of autoregulation, and the upper limit of 150 is kind of like where the data ran out. That explains where the upper limit was. But he sort of hedges his bet. On the x-axis, you see the blood pressure of 50 at the lower limit, but you see that hatched area of hypotension and hypertension. So he kind of thought that maybe a blood pressure of 60 should be considered as when hypotension starts, and hypertension around a mean arterial of 100. But regardless, Lassen's work of a lower limit of autoregulation at 50 millimeters of mercury has stood for 40 or 50 years now, has been untested and has been sacrosanct, and it's in all the textbooks, it's in all the articles and that we read about blood pressure. It's taken for granted that it's true. Well, about 15 years ago, our team that was then at Johns Hopkins began to collaborate with the team in the neurosurgical unit at the Addenbrooke's Hospital, Cambridge University. And this gentleman in this slide is Marek Zazanka, who with his team came up with this method. Marek's a PhD in electrical engineering, and he sort of figured that, we could take signals from some of our physiologic monitors and look at these relationships in real time, and maybe we could derive information about the autoregulation curve on an individual patient, and therefore optimize blood pressure to keep it within the autoregulation range to ensure perfusion to the brain. And I'm not going to bore you with going through all these details. This particular slide is derived from patients who have intracranial bolt monitoring and as well as transcranial Doppler monitoring, which is not, of course, viable for patients other than those in the neurosurgical unit. But one of the things you can look at is the top graph A is the bottom graph is cerebral blood flow, and you see it's constant. The top graph is arterial blood pressure. And basically you see that blood pressure can vary, but flow stays the same. So in this patient, they're autoregulated, whereas the patient in the other panel, C, is not autoregulated. And you autoregulate by changing your blood vessel size, right? So if your blood pressure is going up, your blood vessels get smaller. If your blood pressure goes down, they vasodilate. And the end result of that is if you vasodilate, your cerebral blood volume goes up. Collectively, all those arterioles dilating increase blood amount in the brain and increase your cerebral blood volume, and that can have an effect on ICP. So they propose that by monitoring these changes in blood pressure and blood flow and through ICP, you can derive information about where to optimize blood pressure in a patient with traumatic brain injury. And they've shown repeatedly that if you optimize blood pressure in these patients with increased intracranial pressure from traumatic brain injury, stroke, subarachnoid hemorrhage, that they have better outcomes in terms of functional outcomes and mortality. Well, again, ICP bolts are not applicable to our surgical patients, and transcranial Doppler is difficult to do on a routine basis. It's really a research tool in most instances. But one of the things that we do use clinically is near-infrared spectroscopy. And this is particularly in cardiac surgery, but also in other areas as well. And near-infrared spectroscopy, where we put sensors on the forehead that then send light and look at the absorption of that light from the brain. But we know that most of the blood in the brain is venous blood. 70 to 75% of it is venous blood, which means that what near-infrared spectroscopy provides us is an information about supply versus demand of cerebral blood flow. So cerebral oxygen supply to the brain is controlled by the oxygen saturation, the hemoglobin level, and the cerebral blood flow, whereas demand is the cerebral metabolic rate for oxygen. So NIRS readings represents this balance between supply and demand. Well, several years back, my colleagues at Johns Hopkins and at Cambridge, and led really by Ken Brady, who's a pediatric anesthesiologist intensivist here with us at Northwestern now. But he sort of speculated that, and there was a rationale for why he thought this based on Lycox monitoring of the brain. But he speculated that over short periods of time, might NIRS be used as a surrogate for cerebral blood flow. So again, if NIRS represents supply versus demand, the supply part is oxygen saturation, hemoglobin, and cerebral blood flow. But if you filter these signals out and focus only on these low frequencies associated with autoregulation, and we're talking about signals less than 0.05 hertz, because autoregulation, the vasoreactivity is a relatively slow process. But if we focus just on those signals, might NIRS be used as a surrogate for cerebral blood flow, meaning that changes in oxygen saturation, hemoglobin, or cerebral metabolic rate for oxygen certainly affect NIRS reading, but they probably won't do it in those same frequencies as autoregulation. So if we filter and look at these low frequencies associated with autoregulation, might NIRS provide a signal of cerebral blood flow? And this was a study that Ken performed at Hopkins. We reported it in 2007. And I'm going to walk you through this graph. On the left side, and what they did is they took piglets and they put a small balloon in the inferior vena cava Foley catheter and inflated it at various volumes to control venous return to the heart and therefore control blood pressure. And they measured cerebral perfusion pressure in these animals, and they plotted that on the x-axis. And on the y-axis, they plotted the laser Doppler flux, which is a laboratory method for measuring cerebral blood flow. So they varied the blood pressure in these animals and measured cerebral blood flow, and they then took the data and plotted it. And they fitted two curves to the data and with linear regression, and where these two curves meet is where the lower limit of autoregulation, and that's the dotted, the dashed line down to the x-axis, and you see the lower limit of autoregulation is about 34 millimeters of mercury for cerebral perfusion pressure in this animals. If you go to panel C, what they do here is that they look at the correlation between low frequency changes in cerebral blood flow and blood pressure, and they're focusing on those low frequency changes that happen in the autoregulation index. And what they do is they plot the correlation coefficient, which is LDX. And this is a correlation coefficient. So it's just simply looking at the correlation between flow and pressure at low frequencies. And they do it in 300-second windows that's updated every 10 seconds. So the 5-minute average is updated every 10 seconds. And this correlation coefficient gives us an idea whether blood flow and blood pressure are related or they're independent. If you're autoregulated, they're independent. Blood pressure changes, flow stays the same. So your correlation coefficient's low. So you see, if you compare the blood pressure, cerebral perfusion pressure above the lower limit in panel A, if you go down to panel C, you see that this correlation coefficient is low insofar that it approaches zero, meaning that there's no correlation between flow and pressure. However, when cerebral perfusion pressure drops below the lower limit of autoregulation, flow and pressure now are correlated such that you have the lower the pressure, the lower the flow, meaning that these changes are correlated and now you're below the lower limit. So by monitoring the correlation coefficient between flow and pressure, you get an indication of whether your pressure is above or below the lower limit of autoregulation. So basically, these two panels verify and validate the Cambridge method for monitoring autoregulation. In the panel B, these animals also had near-infrared spectroscopy, and you can sort of see that these data, they started to develop a curve with these data where you can sort of see that when the blood pressure is below the lower limit, the NIRS readings become pressure passive. In other words, the lower the pressure, the lower the flow. And now if you filter this data to low frequencies, we develop a variable we call COX for cerebral oximetry index. And COX is simply a correlation coefficient between NIRS and CPP at low frequencies. This isn't the raw data out of the monitor, it's low frequencies. And what you see is that as the pressure goes below the lower limit in this animal 34, you see that COX becomes positive, meaning that flow and pressure are now correlated. So this paper and this study validates the use of processed near-infrared spectroscopy readings to monitor autoregulation, which we can do in virtually anybody. If they have a forehead, we can put NIRS pads on. If they have blood pressure, we can put those two into a computer and give a result of autoregulation. So we've been at this for a while. And in 2012, Brijan Joshi, who was then one of my fellows, research fellows, we looked at our data and at the lower limits of autoregulations, and these were in patients during bypass. And the x-axis is the mean arterial pressure at the lower limit of autoregulation, and the y-axis is really the number of subjects at each of those lower limits of autoregulation, or what we colloquially call LLA. And you can see one thing that was striking to us is the range. While the average lower limit is 66 millimeters of mercury, with those confidence intervals, the range is 40 to 90. So, if we pick a mean arterial pressure of 65 millimeters of mercury as the lower limit of autoregulation, or as the definition of hypotension, will be right for the average patient, but that's the average patient. There's still many patients who have a higher lower limit of autoregulation, and their definition of hypotension will be at much higher levels. And if you take people who develop CVA strokes after cardiac surgery, we see that they actually have a higher lower limit of autoregulation, such that a mean arterial pressure of 72 is actually their definition of hypotension. So these patients who may have a low blood pressure at the lower limit of autoregulation, certainly if you keep the blood pressure 65, they'll be okay. But these other patients, 65 is too low. So their definition of hypotension is much higher. And what we believe our data now for 15 years and probably 1,000 plus patients is that the definition of hypotension is really an individual definition. Is that if you want to take population-based data and define hypotension, you'll be right for the majority of our average patients, but not for all patients. And it appears that the amount of time you spend below the lower limit of autoregulation has meaning for patient outcomes. We've shown that it's associated with acute kidney injury. It's associated with major morbidity and mortality, which would be a combination of kidney injury, stroke, mortality, and cardiogenic shock after heart surgery. We showed that it's related to stroke, and we also have data to show that it's related to delirium. So the amount of time that you spend with your blood pressure below the lower limit, and we look at like an AUC, or the area under the curve for the duration, but also the magnitude of blood pressures below the lower limit as being a key factor as determined in these outcomes. So our data suggests in retrospective analysis that indeed the time you spend with your blood pressure below the lower limit has importance to patient outcomes. And if we look at the kidney, this is quite interesting. This is a study that my colleague Ken Brady did in animals. And this model, as they took piglets and they did slow hemorrhage model of hypotension, this would be quite similar to what we see sometimes in the operating room where you're losing blood, not drastically, but slowly losing blood and the circulatory volume's gone down. And in the study, the A panel is they looked at the laser Doppler flux to the brain and they plotted cerebral perfusion pressure. So these are autoregulation curves, right, at different blood pressures. And the other panel below that is the laser Doppler flux to the kidney. So they're looking at blood flow to the kidney and they're looking at renal perfusion pressure, or the difference between the artery and the vein pressure. And one of the striking things here is that the lower limit of autoregulation to the brain in panel A is somewhere around 40, 45. But if you go down to the kidney, you see their lower limit is actually probably closer to 55 or 60, such that when you hit in this box, different hatches, box 75%, 50%, 25%, those are absolute blood flows based from normal, compared to normal. So you can see that when you hit the lower limit of autoregulation to the brain in panel A, around 40, the kidney, at that same blood pressure, their blood flow is approximately 75% of normal. So in other words, when you are now hitting the lower limit of blood flow to the brain, the kidney is only receiving about 25% of normal of blood flow. So as we say, that the time you start to decrease blood flow to the brain, your kidneys are already being strangled. Now, fortunately, not all blood flow to the kidney is, I should reverse that, a lot of blood flow to the kidney is simply for filtering, not necessarily for oxygen delivery. So this doesn't necessarily mean that there's renal ischemia, but it is set up for that. I don't have time to go through all this, but one of the interesting things is that the kidney not only needs blood pressure. If you read this paper very carefully, you'll see this, that the kidney does not only need blood pressure, but it needs flow. On bypass, it needs cardiopulmonary bypass flow. After bypass, it needs cardiac output. So the kidney is not merely ruled by blood pressure, but it also needs blood flow. So when we look at blood pressure cutoffs for kidneys, it's very obvious why low blood pressure would lead to acute kidney injury, but that's not the only variable. It's also flow. So we've done multiple studies over 15 years, and I can be sure glad to provide you a bibliography, but this is a Lassen curve, again, of flow versus pressure, and we've shown from multiple publications that the amount of time you spend with your blood pressure and the magnitude below the lower limit of autoregulation is associated with bad outcomes, with organ injury. But simply raising the blood pressure, in other words, we say, well, look, if the average is 66, let's just raise our blood pressures. Let's just keep everybody's blood pressure at 80. Well, the other side of the coin is that when you approach the upper limit of autoregulation to patient's brain, this can lead to hyperemia. In other words, you have higher pressures, higher flow. And if you can imagine the situation of cardiopulmonary bypass, for example, or other situations, sepsis in the ICU, or other major trauma surgery, is that you have leaky capillaries, and you may also have a lot of emboli in the circulation. So hyperperfusion or hyperemia to the brain is not necessarily a benign event. In fact, hyperemia of the brain is one of the causes of hypertensive encephalopathy, where you have patients come to the emergency room with hypertensive encephalopathy. They're delirious, and it's because of hyperperfusion to the brain. We went through our data. This was a cohort of nearly 500 patients who we had monitored autoregulation with Cox. And we found that on average, the upper limit of autoregulation was 90, but it ran between 88 and 91. But the time that you spend with your blood pressure, sort of the area under the curve of blood pressure above the upper limit, was actually associated with delirium. So the idea that if you have to keep your blood pressure above the lower limit to perfuse organs, but you can't have it so high that you're hyperperfusing organs, particularly the brain. So you have to have a sweet spot for individual blood pressure management to be ideal. And we believe to do that, you need to monitor autoregulation. Again, this idea of magnitude and duration of blood pressure above the upper limit predicted delirium. Now, it's not the only factor that predicted delirium. Other factors were even stronger, but it's the only modifiable risk factor that we found in our studies. So we were very fortunate to have funding from the National Institutes of Health and National Heart, Lung, and Blood Institute to do a randomized study of patients' blood pressure management during cardiopulmonary bypass. What we did is we took patients and we before surgery, we did battery cognitive tests and other tests. And then at the time of surgery, after the patients were intubated, we randomized them into a group who had usual care. In other words, the perfusionists could decide and the clinicians could decide where to keep the blood pressure, versus an intervention arm where we monitored autoregulation and we told the perfusionists and the anesthesiology team what blood pressure the lower limit of autoregulation was. And therefore they could manage the patient individually versus treating everybody the same. This was a nested study within that study by my colleague Charlie Brown at Hopkins. And Charlie he came on faculty several years after I started my trial, and he became an expert, is an expert on delirium and geriatric syndromes. He started monitoring our patients carefully for delirium using this validated tools, the infusion assessment method for the ICU when they were intubated, just CAM when they weren't intubated. And we we trained our research team very, very carefully. We had quality control procedures. Karen Newfield's the second author. She's a psychiatrist expert in delirium. And we adjudicate all events through a very standardized process. And this is the flow diagram of our study, our nesting study, and within our bigger study. And one of the things, well, this is basically, if you look at the AUC, or the area under the curve, that blood pressure was below the lower limit. Autoregulation group actually had less than the standard of care group. So we do have a dose response intervention that led to less time to get blood pressure below the lower limit when you monitor it. But our delirium in the standard care group versus the intervention group was significantly lower. It's about 28% lower, or 45% lower frequency, but about a 28% reduction in the odds of developing delirium in the intervention group. If you intervened by monitoring autoregulation, you could reduce the frequency of delirium by 28% according to these data, single-center data. So we think that this is exciting. We think it needs to be confirmed in a larger data set, multi-center study. There's very few downsides monitoring autoregulation. They may get more phenylephrine during surgery, the patients, but we cannot find any differences in major organ injury as a result of that. I know we worry about giving vasoconstrictors and the effect on the kidney, but our data would suggest that as long as you keep the blood pressure in the autoregulation range, it's not associated with any organ injury. Now, these were in patients who had arterial lines for heart surgery. We've also have data that you could do this non-invasively as long as you have a continuous blood pressure reading. This was just a photo. We did a study in patients having shoulder surgery. The issue is if you put someone in the beach chair position, what's the right blood pressure for monitoring perfusion to the brain? And we monitor these patients with this plasmographic phenopress method, which is the precursor of the new Insight method and other methods, to monitor a continuous blood pressure signal in patients. And we show that you can monitor autoregulation non-invasively in non-cardiac surgery too. This paper was published in Anesthesiology a few years back. So I'm going to conclude my lecture with that. I think our data is, thus far, over 15 plus years, shows that the definition of hypotension is an individual definition. It's not accurately based on population data. You can derive some sort of indication what might be the lower limit of what might be the blood pressure for patients, but you're not going to be completely right. And we show that this precise definition of hypotension may be a potential modifiable way of avoiding organ injury, but certainly delirium and maybe cognitive changes. So we propose to go forward to monitor this, to perform future studies to confirm that hypothesis. So again, thank you very much. This is a nice picture of our medical school and our medical campus here in Chicago, and we certainly look forward to seeing you here in the very near future.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.